Podcast 6 of the Abdomen series, the liver and spleen. This podcast will describe the anatomy of the liver and spleen, detailing their structure, location, peritoneal coverings and blood supply. So let's start with the liver. This is the largest gland in the body after the skin and is mostly located in the right hypochondrium and epigastrium regions. Sometimes particularly large livers can extend across to the left hypochondrium. It has numerous functions, including detoxification of nutrients from the gut, various metabolic processes, glycogen storage, and the production of bile for fat breakdown. The bile is transported from the liver via the hepatic ducts, which form the biliary tree, alongside the cystic duct from the gallbladder and the pancreatic duct from the pancreas. And I'll detail the biliary tree and its association with the pancreas, liver and gallbladder in the next podcast, number 7. So for the first part, let's focus on the liver and concentrate on its surfaces, peritoneal reflections, lobes and blood supply. The liver has got both a diaphragmatic and visceral surface. The diaphragmatic surface is smooth and convex, and it sits under the right dome of the diaphragm. It extends from the sharp inferior border of the liver and covers its anterior, superior and posterior aspect. The visceral surface covers the inferior part of the posterior aspect and also meets the diaphragmatic surface at the sharp inferior border. The diaphragmatic and visceral surfaces of the liver are separated from the surrounding structures by two recesses, the hepatorenal and subphrenic. Both of these recesses form the superior limit of the greater sac and are formed as the peritoneum is reflected from the liver and it attaches to either the posterior abdominal wall or the diaphragm. The hepatorenal recess is a peritoneal-lined cavity that has the visceral surface of the liver superiorly and the right kidney inferiorly. This is an important recess and it is the lowest point of the abdominal cavity when in the supine position, and fluid can collect in this recess from the infracolic compartment by passing through the right paracolic gutter. The subphrenic recess is also lined by peritoneum and is located between the superior surface of the liver and the diaphragm. This recess can be divided into right and left parts by the falciform ligament, which extends from the liver to the anterior abdominal wall. So now let's turn to the liver's peritoneal coverings. Now the liver is mostly covered with visceral peritoneum, except for a triangular shaped region on the posterior surface. This is the bare area. This bare area is formed as the peritoneum that covers the liver is reflected towards the diaphragm. This site of reflection occurs at 2 points, and these reflections of peritoneum are the anterior and posterior coronary ligaments. So as the visceral peritoneum that is covering the anterior and superior surfaces of the liver extends to the posterior aspect, it is reflected from the liver's surface to run superiorly to the diaphragm, and this is the anterior coronary ligament. The posterior coronary ligament is formed in a similar way as the visceral peritoneum extends along the visceral surface of the liver, and as it reaches the posterior aspect, it is reflected from the liver's surface to run inferiorly to the posterior abdominal wall, where it then continues as parietal peritoneum. The two coronary ligaments converge on either side of the liver to form the left triangular ligament on the left side and the right triangular ligament on the right side, and these anchor the liver to the diaphragm. Now before we turn to the lobes and subdivisions of the liver, I just want to spend some time describing the visceral surface of the liver in a bit more detail. So the visceral surface is slanted diagonally downwards from the rounded supero-posterior surface to the inferior border and is completely covered by visceral peritoneum except at the porta hepatis and gallbladder fossa. The visceral surface is characterized by numerous fissures. There are 2 sagittal fissures that are linked by the transverse porta hepatis, and this forms an H-shaped impression. The right sagittal fissure is in line with the inferior vena cava and gallbladder, and the left sagittal fissure separates the left lobe of the liver from the caudate and quadrate lobes. Running within this left fissure are 2 ligaments, the round ligament anteriorly and the ligamentum venosum posteriorly. The round ligament is the fibrous remnant of the umbilical vein, which transmitted nutrient-rich, oxygenated blood from the placenta. It extends to the umbilicus on the anterior abdominal wall by running in the free edge of the falciform ligament. The ligamentum venosum is the fibrous remnant of the ductus venosus, which merges with the inferior vena cava. In the developing fetus, this duct shunted blood from the umbilical vein to the inferior vena cava, thereby bypassing the liver. The final structure on the visceral surface I want to detail is the porta hepatis, and this encloses the portal triad. The porta hepatis links these two sagittal fissures, and the portal triad within it contains three structures: the hepatic portal vein, the hepatic artery, and the bile duct. These three structures enter or leave the liver by running in the hepatoduodenal ligament of the lesser omentum. And remember, this extends between the porta hepatis and the first part of the duodenum. The second ligament that forms the lesser omentum is the gastrohepatic ligament, and this runs between the lesser curvature of the stomach and the ligamentum venosum within the right sagittal fissure. So let's turn to the lobes and subdivisions of the liver. The liver can be anatomically divided into two main lobes and two smaller accessory lobes. The two left and right main lobes are separated by the reflection of the falciform ligament anteriorly and the left sagittal fissure inferiorly. This division makes the right lobe considerably larger than the left. On the visceral surface, there are the two smaller accessory lobes, the caudate and quadrate, and these form part of the right lobe. The caudate lobe is located between the inferior vena cava and the left sagittal fissure posteriorly, and the quadrate lobe is between the gallbladder and the left sagittal fissure anteriorly. The shape of these two accessory lobes can be fairly variable, and an easy way to remember the location of the two accessory lobes is that the caudate lobe lies next to the inferior vena cava, using the C from cava to remind you of this location. Now, alongside these four anatomical lobes, the liver can be surgically divided into functional left and right parts, again by the falciform ligament anteriorly and the right sagittal fissure inferiorly. These two functional parts are supplied by either the left or right branch of the hepatic artery, which means that each half can function independently. Both of these left and right functional parts can then be further divided into two divisions, with each division divided into two segments. So this functional description of the liver gives rise to left and right parts, 4 divisions, and 8 segments. Each of these 8 segments are functionally independent, with each segment receiving a branch from the hepatic artery and a branch from the hepatic portal vein, and each segment giving rise to an hepatic duct and also an hepatic vein. This segmentation means that the liver is effectively 8 independent mini-livers, and this arrangement can be exploited surgically with hepatic lobectomies and segmentectomy. These procedures utilise the independent nature of these segments and means that the right or left parts of the liver, or various segments, can be removed with the safe knowledge that the remaining segments can still function and there will be no danger of excessive bleeding. Lobectomies or segmentectomy are crucial in the removal of parts of the liver damaged after trauma or affected by a tumour. So to finish detailing the liver, then we need to consider the blood vessels of the liver. Now, the liver is responsible for detoxifying all the nutrients that are absorbed by the gastrointestinal system. All of these nutrients pass to the liver via the portal system of veins that drain the foregut, midgut and hindgut. The various veins that make up the portal system converge to form the hepatic portal vein that runs within the free edge of the lesser omentum in the hepatoduodenal ligament to enter the liver at the porta hepatis. As the hepatic portal vein enters, it divides into numerous branches which supply each of the 8 segments. The hepatic portal vein brings about 75 to 80% of the liver's blood supply, with the remaining 20 to 25% being from the hepatic artery, which is a branch from the celiac trunk. The hepatic artery runs alongside the hepatic portal vein in the free edge of the less omentum, and as it enters the liver, it divides into right and left hepatic arteries, which supply the right and left parts of the liver. The final blood vessels to mention are the hepatic veins. The hepatic veins return the newly detoxified venous blood to the venous system by draining directly into the inferior vena cava as it passes along the inferior visceral surface of the liver. In the second part of the podcast, I'm going to describe the spleen. The spleen is a soft, fist-sized organ that is positioned in the left hypochondrium and has the 9th, 10th and 11th ribs protecting it laterally, and it sits on the splenic flexure of the colon. It is made up of a mass of delicate lymphoid tissue that is purple in colour and participates in the body's immune system by producing lymphocytes. Prior to birth, it is involved in producing red blood cells, and after birth it becomes a filter for removing and destroying damaged red blood cells, and it can also act as a reservoir, storing blood and platelets. The surface of the spleen is smooth, and it is convex and sits against the diaphragm. It has a sharp anterior and superior border, which usually contains some indentations, and it has a rounded posterior and inferior border. The spleen is completely enveloped by peritoneum, except at its hilum, and is in contact with the stomach via the gastrosplenic ligament, and the kidney via the linorenal ligament. The splenic artery enters the spleen at its hilum, and is the largest artery to branch from the celiac trunk. It takes a characteristically tortuous course along the superior border of the pancreas to pass between the two layers of the linorenal ligament. Sometimes the tail of the pancreas, which also runs in the linorenal ligament, extends along with the splenic artery to the hilum of the spleen. The spleen is drained by the splenic vein, which travels alongside the splenic artery across the abdomen to form the hepatic portal vein with the superior mesenteric vein and enters the liver. So in this podcast, I've detailed the liver and the spleen. In the next podcast, number 7, I'm going to describe the gallbladder, pancreas, and the biliary system.